Hello, this is Selina Luger from the University of Pennsylvania in Philadelphia, PA, and I'm here to discuss what are the current challenges in ALL therapy. I think there are several challenges in ALL which are fortunate for us because we now have choices and questions when before we really did not have that many opportunities because we didn't have that many agents. So I think we can break it down into several areas. The first is, do patients all need transplants for ALL? There is now some data that with some of our newer agents, we might be able to achieve MRD negative status to the point where there may not be a clear benefit for all patients to undergo transplant. There is data that has been presented by Dr. Rivera at SOHO discussing several scenarios, such as those with Ph positive disease who become MRD negative, or even those with Ph negative disease who become MRD negative, who might do well even without a transplant. But what we need is some randomized trials to understand which patients still do need a transplant and which ones can do well without one. Another area that can be looked at in terms of clinical equipoise is the question of whether or not patients with Philadelphia chromosome-positive leukemia need intensive chemotherapy or whether they can do well without intensive chemotherapy. Data from MD Anderson looking at hyper-CVET-M ponatinib demonstrates that a significant number of patients achieve MRD negative status and that a good number of those patients do well without allogeneic transplant as well. Data from Italy, however, looked at the D'Alba study combining blinatumomab with TKIs, and again demonstrated, although with short follow-up only of 1 year, that a good number of patients had excellent disease-free survival. So we look forward to an upcoming trial that is going to be conducted by the cooperative groups in the US that is actually going to compare intensive chemotherapy to blinatumomab-based chemotherapy together with TKIs in patients with Ph-positive ALL. And then I think the next question that comes up is, are there patients even with Philadelphia chromosome-negative ALL who can do well without chemotherapy? And this is particularly important in the elderly patient population where chemotherapy is not well tolerated at all. And so there are some studies ongoing that will be looking at the use of chemotherapy-free regimens using blinatumomab and inotuzumab together or in sequence to see if patients can do well without any chemotherapy at all. The next set of questions involves using these targeted agents in chemotherapy regimens. The ECOG 1910 protocol has just closed, looked at whether or not adding blinatumomab to patients who are MRD negative is of benefit, and the current adolescent young adult study is looking at the role of inotuzumab in patients with ALL in remission. And so we await studies that will answer those questions. And then I think the last challenge that we have to deal with is really T-cell ALL. Everything I've spoken about so far is B-cell disease, and we still do not have any targeted agents per se for relapsed T-cell disease. There are, however, some agents on the horizon that look interesting and some studies that will soon be ongoing, and also some questions about whether or not there is a role for CAR T-cells even in T-cell ALL. And so I think that sums up many of the challenges that we're now facing in ALL. Thank you.